welcome you all on today's webinar on the topic Evidence-Based Assessment and Management of Shoulder Internal Impingement in the Overhead Sports. Before we begin this session, I would like to sincerely thank our IAP President, Dr. Sanjeev Jha, IAP Women's Cell National Head, Dr. Ruchi Varshne, North Zonal Head, Dr. Deepti Goyal. I would also extend my thanks to organizing committee for this webinar, the members of IAP Women's Cell Punjab team, Dr. Devinder, Dr. Jitendra Sharma, Dr. Amandeep Singh, Dr. Harpreet Bawa, and Dr. Lalit Arora. Last but not the least, I would like to thank IAP technical team for their support. Before I hand over to Dr. Smarak Mishra, I would like to inform all the participants that if you have any queries, please put them in the chat box and these will be answered in the end of the webinar. And just before I hand over to Dr. Smarak, I would like to say a few words about our speaker, Dr. Smarak Mishra. Dr. Smarak Mishra, he is passionate about learning and teaching since very young age. He has more than 18 years of experience, of teaching experience. He completed his BPT in the year 2000 from Netar, Cuttack. He completed his master's degree in sports physiotherapy from GNDU, Guru Nanak Dev, Amritsar in the year 2003. In 2011, he completed his second master's degree in academic practice from the Manchester Metropolitan University. He is currently continuing an MBA degree there. Dr. Smarak Mishra, he has worked as a clinician, lecturer, and assistant professor in various clinical and academic setups in India. Prior to joining the Manchester Metropolitan University in the year 2006, he worked as Vice Principal of the School of Physiotherapy in MGM Medical College, Indore. Currently, he is working in Manchester Metropolitan University as an exams officer on the UG program and is responsible for development of virtual learning environment for different units. Dr. Smarak Mishra has a keen interest in research and has presented various research.
Can you hear?
He is registered with the Healthcare Professionals Council UK. He is a member of Chartered Society of Physiotherapists UK. And besides this, he is a member of various professional associations. Dr. Smarak Mishra, now I would like to request you to kindly start the session, sir.
Hi, Reena. Thank you very much for the nice introduction. Prior to starting, I'll just say a couple of things. First, really, I want to apologize for this delay. There are some technical issues. I understand you can appreciate the difficulty nowadays with everybody trying to use the same network. But I'll first start with thanking IAP to give me the opportunity. And a lot of thanks to Reena for organizing this. I know Reena for a while now. There you go. I should start. Couple of amendments to the introduction. First, I've completed my MBA and now I've moved on to sports and exercise medicine. I'm the program leader for sports and exercise medicine in Manchester Metropolitan University. So without further delay, we can start. Now, I have decided to dump PowerPoint altogether, okay? And I'll try to do it basically through demo, because I know physios are very hands-on. They like things being done. They like to see things. So I decided, I was pondering about whether to use a PowerPoint or not. So I have decided to get rid of it altogether. So first thing, how many of you actually have played sports? if you have played sports, how many of you have played cricket? How many of you have played tennis? How many of you have done a javelin throw? Or how many of you have played badminton? If you think about all these sports, what is common is that your shoulder is going up and outwards, and then you're doing the movements. Sorry, I'm left-handed with more powerful stuff. I'm ambidextrous, so I'll show you using my left hand. So if you're going for any overhead activities, your shoulder is going through the full range of motion. Okay, that leads to some of other issues. Now, if you know about shoulder, you know that the cliche is that stability is compromised for the sake of mobility. Okay, I'll repeat that: stability is compromised for the sake of mobility. That means shoulder is inherently an unstable joint. Okay, so how is the joint stabilized then? It's mostly the muscles, labrum, ligaments that stabilizes the joint. When we're doing our regular day-to-day activities, it's not going to matter that much because we're not using the full range of motion or excessive range of motion. So the shoulder is in its zone, so to speak. But when we try to do stuff which are excessive, for example, in overhead activities where you are trying to generate a lot of force, you tend to end up with a certain other kind of problem that is not evident in day-to-day activities. Now, if you have practiced in musculoskeletal physiotherapy or in outpatient, you must have seen shoulder impingement. Now, shoulder impingement, you would personally think that it is the subacromial impingement. I assume all of you have got some basic understanding of the anatomy of the shoulder and the subacromial space. What I'm going to talk about today is not about subacromial impingement, but it is another form of impingement which is often misdiagnosed. And to understand it, it is very essential to understand why it happens, and particularly why it happens in overhead shoulder injuries, shoulder athletes. Okay, so I have got some equipment here. Rather than talking you through it, I will do the demo. Now, imagine that I am a cricketer, okay? I love cricket. I used to play cricket myself. Now, if I am fielding on the boundary, the ball comes to me, what I do is to catch and then throw to the wicket keeper, okay? Now, if you look at this movement from the side, you can see that when I hold the ball, I go up, okay? So this is the biomechanics I'm going to talk about. I go up, so I'm generating force from the large muscles of the lower limb, then to the tummy, and then transferring it to the shoulder. This phase is called the wind-up phase, okay? So after the wind-up, you go into this position where your arm is abducted to 90 degrees and externally rotated. This is called the cocking. So first phase, wind-up. Second phase is cocking. Can you see the shoulder here, the position? And then what happens is you throw the ball, okay? So that requires a large amount of force produced by the flexors and internal rotators of the shoulder, okay? And once the ball is released, okay? Once the ball is released, then you go down and basically dissipate the force in the lower extremity. Now, this chain of sequence is quite important in understanding the pathomechanics of injuries, okay? Now, before I say anything, I must say the camera is controlled by my 12-year-old. So if it is jittery, please excuse. She's off school now, so she has got a job to do. So to recap, wind up, cocking, acceleration, release, and deceleration, okay? So these are the 5 phases in throwing, okay? So if you think about tennis, look at what happens in tennis. Now, in tennis serve, you go for this activity, right? So release the ball, then at that point you have gone on to the cocking phase, then hit, which is the release phase, and acceleration goes, hitting, and then deceleration, okay? So again, I'm repeating. So you're going to throw the ball up, then go into this cocking phase. In cocking phase, you're going to sort of go forward and hit the ball, okay? And then you decelerate. So fairly similar. Some Um, some sort of biomechanics resources classify our tennis to have 8 phases as opposed to 4 phases, but the main 4 phases are this. Okay, think about badminton, same sort of thing if you're going for overhead activity. Now, what is happening is you are sort of taking the arm into maximum external rotation. Okay, it's called cocking, like it is like a gun. The gun is cocked, and then it basically stretches your internal rotators. Can I remind you of this internal rotators of the shoulder? If you think about the internal rotators, we have got the pectoralis major, latissimus dorsi, teres major. These are large muscles. Okay, as opposed to these large muscles, if you think about the smaller muscles doing the external rotation, can you remember which muscles do external rotation in the shoulder? I'll give you a couple of seconds. It's basically teres minor, okay, one of the rotator cuff muscles, and infraspinatus, again, another rotator cuff muscles. Now, rotator cuff muscles are fairly small muscles. So if you think about the force being generated by the large muscles, internal rotators, as opposed to the external rotators, there is an inherent imbalance within that. So here comes the notion of internal impingement, sometimes called as the posterior impingement. So when you are going into this phase, the cocking, that's where the patients start complaining of pain in the shoulder. It's generally a pain deep within the shoulder, and it's like a toothache kind of pain. Otherwise, when it is pinching, it's a sharp kind of pain, right? So often when they come to outpatient department or even sports physiotherapy clinic, they're diagnosed as having impingement. Yes, they are having an impingement, but this impingement is very different from that we see in sedentary individuals where there is subacromial impingement. Okay, so if I may just, so I don't have a skeleton at home, I'm live streaming from the kitchen here in the UK. So if I just show you what happens exactly. So when our shoulder is externally rotating in the cocking phase like that, the shoulder starts moving. I'm going to come close. The humeral head starts moving forward. Okay, when it starts translating forward, then what happens? The posterior aspect of the glenoid labrum pinches on the posterior aspect of the shoulder. Okay, I repeat again. So when the shoulder starts going external rotation into the cocking phase, the shoulder translates forward if the muscles are not controlling it, and the posterior aspect of the humerus head pinches with the glenoidal labrum. Okay, and that causes the classical pain. Okay, and this is called the posterior impingement syndrome. Now, posterior impingement syndrome was coined by Diksha, can I have? Yeah, that. Sorry, I don't remember names very well. So posterior impingement syndrome was coined by Ludwig and Bremen in 2011. And they said that classically it has got 3 aspects. One is the shoulder instability. Second is some deficit in the rotator cuff. And the third point is impingement of the rotator cuff. Okay, so classically we find that there is anterior instability of the shoulder. Imagine the shoulder is going back and forth hundreds and thousands of times. Okay, what will happen to the anterior capsule? Every time the shoulder humerus head is pushing forward, and the anterior capsule becomes laxed. When the anterior capsule becomes lax, the posterior capsule becomes tight. So the posterior aspect of the shoulder, the capsule becomes rather tight. So anterior laxity followed by posterior tightness. The other thing that happens is if you compare 2 sides internal rotation of an overhead athlete, in us we find that it's pretty similar if you try to measure the internal rotation. Here, the internal rotation on the side of throwing or smashing will be considerably less. So the internal rotation on the non-throwing arm or non-overhead arm will be much higher, but this one is lower. So that internal rotation deficit is also an important factor, and that's because there is posterior capsular tightness. Okay. Now, why does the internal rotation deficit occur? That occurs because of some bony changes, because if you have been doing it for 10, 15 years, there would be bony torsional changes. So the bone rotates over itself. We can't correct that, unfortunately. Or else it could be because that you have kind of habitually lost that range of motion. The problem with losing internal rotation is that the posterior capsule is preventing you from keeping the head of the humerus in the center. So if that doesn't happen, then it will translate forward and it will cause impingement. That's why when you treat a patient with internal impingement with the traditional treatment of subacromial impingement, they don't respond very well. In fact, many of the sports persons who have that issue will tend to sort of say that it's not improving. In fact, with the treatment, it's gone worse. So what do you do in this case? Right. Now, now you understand the biomechanics of the overhead sort of sports, you can think about what you can do. So ideally, I should hold, or I should try to keep my head of the humerus within the glenoid cavity without maximum translation. What's causing that? Because there is weakness or imbalance in the rotator cuff that's leading to this problem. Now, you might ask, what structures get impinged here? When it rotates, when the head of the humerus rotates externally, in fact, it is the supraspinatus and infraspinatus that tend to sort of get impinged. Now, how do you know that it is a posterior impingement as opposed to subacromial impingement? This is where the evidence-based assessment comes. Now, because this is specific to sports, the assessment has to be more than what you do in musculoskeletal practice. For example, if you just go for Neer's test or any other impingement test, it won't come positive here. Okay, so you would think, okay, it's not positive, so it's something else. Could be a rotator cuff issue. Yes, it is a rotator cuff issue, but the rotator cuff is being pinched on the posterior side. So to assess, first of all, what you are going to do is to check for the scapular mobility. And this condition doesn't usually occur. The pain does not usually start very early in the movement. So let's say that the patient comes in or the sports person comes in and you say, okay, can you serve? And he serves, or can you throw? He throws. He says there is no pain. But he says that after playing for about 30 minutes, I start experiencing pain in the posterior aspect of the shoulder and I can't continue after that. What does that mean? Any ideas? That actually means that the muscle has got some role in the pathomechanics of it. You know, rotator cuff centers the head of the humerus in the glenoid cavity, and with activity for 30 minutes, the rotator cuff small muscles start getting tired, fatigued. Now that fatigued muscle will not hold the head of the humerus in the center very well. And that's where the translation starts happening. Okay, so we need to check for repetitive movements. So if a patient comes to you or sports person comes to you where there is pain in the posterior aspect of shoulder, ask when does it occur. If they say that it occurs after about 10-15 minutes of play, then you know that there is fatigue. Okay, so what you need to do, so you have to replicate that. Ask them to come to you immediately after playing about 20 to 30 minutes and then check. When you check, you need to check for the scapular movement. Often we know from evidence, Kibler in 2011 suggested through experiments that when you are going for this external rotation and abduction cocking phase, what is lacking is generally the rhomboids muscle power. Okay, what does rhomboids do? Any ideas? Rhomboids usually go for retraction of the scapula. Now, why do you think retraction of the scapula is important? Assuming that my rhomboids is weak, all the force I'm trying to generate is from the shoulder itself. Now, if the scapula is not retracting like that, there is a hyperangulation here. So if the scapula retracts, this is in line. If the scapula does not retract, the shoulder goes back, the elbow goes back, but the chest remains front. This is called a front on action. You must have seen many cricket bowlers bowling like that. Okay, front arm action. They're bored like that. Many tennis players go for a front stance. These are technical issues. Okay, so that leads to the problem, because if your elbow and the shoulder are not in line and the scapula is not retracting properly, that hyperangulation causes the posterior impingement. Does it make sense? So classic thing to look for after 10 to 15 minutes of activities, can they retract their scapula as much as they could do when they're not fatigued? The next thing to look for is how the shoulder moves, because there is anterior instability of the shoulder. If you go for a posterior pressure on the shoulder, Diksha, can I have you as a model, please? Come over here, please. Have a seat. Sorry. So if I'm applying a pressure here and the sports person says, I have got a bit of uncertainty about the pressure itself, or I'm feeling unstable, that tells about the instability. Thank you very much, Diksha. So check for anterior instability as you would check in case of, let's say, shoulder dislocations, recurrent shoulder dislocations, etc. Okay. The third thing to look for is the power of the rotator cuff. Individually trying to assess the power of supraspinatus, infraspinatus. Okay, you all know how to check the power of supraspinatus. Essentially, you are going to do it in scaption, scapular abduction plane, and resist the abduction. Is it good enough, as good as the other side? Then infraspinatus, same thing with thumbs down. Okay. Then you can also check infraspinatus in external rotation position. Check if there is muscle imbalance in the rotator cuff. Okay. Also check for the power around the pectorals, and on the posterior aspect, the power around the rhomboids, latissimus dorsi, etc. Any imbalance there might indicate some issues. But in sports, mind you, the front muscles are supposed to be stronger than the back muscles. That's because you're repeating this explosive activity many number of times. You expect your pectoralis major, teres major to be stronger than the teres minor. But a massive difference in power may lead to impingement as well. Okay, so in that case, you have to strengthen the muscles that are weaker, but keeping in mind that that differential would exist in sports. Okay, so these are the basic assessment. You will do a thorough shoulder assessment, but on top of this, you are going to check for three things: hyperangulation of the scapula. Then you're going to check for rotator cuff muscle strength in terms of comparison. Okay, and you are also going to check for the posterior capsular tightness and anterior capsular instability. So these three things, evidence suggests that are important in the assessment of posterior impingement of the shoulder. All other tests and all other assessments would be done as usual. Okay. So now that your patient has come and you suspect a posterior impingement, you know the biomechanics, you know that there is this issue of impingement on the posterior side. How do you treat it? Okay. In fact, before the treatment, you need to think about what are the differential diagnoses. Now, often posterior impingement comes along with subacromial impingement. They are not always independent of each other. Because of posterior impingement, you sometimes end up with a slumped posture, protracted shoulder, and that means that internal impingement comes with subacromial impingement. Okay, now when I say internal impingement and posterior impingement, don't get confused. They're the same thing. Posterior impingement, internal impingement are the same thing. Subacromial impingement and external impingement, again, are the same thing. Okay, so in terms of treatment, what do we do? So if we know the problem, we know the solution. Physiotherapy is not rocket science. If you can understand the pathomechanics, the treatment part is easy. Now, if it is acutely painful, okay, obviously you will think about protection rest, ice, compression, etc. Elevation is something that is avoided here. If it is, you can think about some electrotherapy, but there is not much evidence about electrotherapy in the management of impingement syndrome, although it is practiced quite a lot, especially in India. Um, Generally, rest from aggravating activities or relative rest from aggravating activities is important. But you're talking about high level players. They can't take rest forever because they will decondition. Okay. So essentially, initially a little bit of rest, and as soon as the pain subsides or reduces to a manageable level, you are going to, you're going to start doing the exercise. Exercises are the main frame of management. Okay. Now, because I'm using my headphone, I can't see whether you participants are engaged or not. May I just ask Reena, can you still hear me?
Yes, sir.
Okay, that's fine. Thank you very much. So usually I speak to hundreds of students in the university. Speaking to a camera doesn't come naturally to me, so I have to check for this. Right, next bit, management aspect. So first thing, when the patient comes, you know that there is an impingement on the posterior aspect. You try to solve the problem using electrotherapy, ice, etc. Then there is relative rest. The next stage is exercise, and exercises can start as soon as possible, as soon as the pain subsides below 5, and that happens pretty rapidly. So what kind of exercises can we do? Now, because it is to do with muscle imbalance, we are going to do exercises that are related to muscle strength. I'll show you some very basic exercises that are useful for this particular condition. Diksha, are you ready with the camera zooming and panning, etc.? Okay. Okay, so we'll start with the basic exercises. The first thing that we tend to do, let's say that my right side is affected, okay? We know that protraction is an important component and so is retraction, okay? So what I would do, I'm just going to sort of face sidewise a little bit so that you can see. I'm going to press on the ball, okay? Now that produces a counteractive force between the retractors and the protractors. Although it's mostly serratus anterior activity, we know that the rhomboids kicks in to stabilize because it's not moving. Then you can go for a rolling of the ball here, okay? This is co-contraction. If you know PNF, you know that co-contraction stabilizes. So it stabilizes muscles around the rotator cuff, okay? And you can go for a large circle as the pain reduces, okay? This is for mobility as well as stability, okay? Then in more advanced cases, you can lean on it and basically go for small rotations, large rotations. You can go anti-clockwise, clockwise. So these are the progressions. Very simple exercises to begin with, not very painful because it's not challenging the entire range of motion. Going on, the next exercises are a set of exercises that can be done in lying down position. Okay. So in lying down position, the first exercise that is generally done is the rowing exercise. Now, why is it important? Because if you remember, I mentioned that retraction, hyperangulation occurs because of rhomboids weakness. So if you do that activity, okay, let's say 30 repetitions, 3 times, and strengthening by rhomboids, that will prevent the hyperangulation, okay? So that's first exercise. The second exercise that you can do in this patient is just shoulder extension. We know that if you go for shoulder extension activity, the posterior triceps also stabilizes the head of the humerus, okay? The third exercise is thumbs down, okay, and a horizontal abduction, but we can do this in 30 degrees of vertical abduction. So here, now this is quite useful for middle trapezius. Again, stabilization of the scapula happens very well there. Okay, 30 repetitions. Okay, now fourth exercise is quite critical in terms of the angle. Here you can basically put the thumb up, go at almost like from 90 degrees to 180 degrees in the middle, okay? and go up. This is quite a difficult exercise, guys. Okay, so don't start with a lot of weight. Even in very muscular individuals, you should avoid using too much of weight. These are setting exercises. The aim is not to bulk up the muscle, but because of pain, the muscle gets inhibited. And here, these exercises would prevent muscle disuse atrophy and also start setting the muscles for further stronger exercises. Okay, first 4 exercises in line, very easy. Okay, then some exercises in sitting. One of the simplest exercise to begin with in phase 1 of rehabilitation is to lift your bottom arm using the shoulder. Do you know which muscle might be used in this activity? Any ideas? Right? Latissimus dorsi. Okay. Now, lat dorsi is a strong internal rotator and scapular stabilizer. So all these exercises so far are targeting scapular stabilizers as opposed to the rotator cuff. That means we have to deal with the rotator cuff as well. So scapular stabilization happens simultaneously. We start rotator cuff. I know that most of you would be more versed with rotator cuff set of exercises as opposed to scapular stabilization exercises. So I'll show you some very simple sort of exercises that are expected to be effective. Okay. So the first exercise that I would suggest is to think about the throwing activity. When you throw, how does that happen? Okay, so this is just resting or resisting the throwing activity here. Okay, now for your external rotation and internal rotation balance, you need to think about a position where this resistance band is going to act against external rotation. Now, this is for internal rotation. I would advise internal rotation strengthening, perhaps towards the end of it. Okay. For external rotation, this is what you are going to start with. You can go for this movement. Now, always have something underneath the axilla because you have got the axillary artery which can get compressed in shoulder adduction positions. So have something underneath the axilla and go for rotations. Again, these are not very strong exercises. They're setting exercises. So start with external rotation, then go for internal rotation. Okay. Right. Now, on the later phase, you can integrate more powerful stuff like the PNF pattern. Okay. So let's say that you have now gained some strength. So rather than going for dull exercises, you go for the pattern. Okay. So this is going into adduction, extension, and internal rotation. So if I just move forward a little bit, this is a strong internal rotation activity. Okay. So again, leave it to the end, but first start with the external rotation pattern, which can be easily done by holding one foot. Okay, Diksha, can you just check the camera? Just show the foot, please. Yeah, and going for external rotation patterns like that. Okay. Right. So these are some of the rotator cuff exercises that can be done. But dealing with the problem just at the shoulder level does not work. Okay. So a lot of core stabilization activity is needed to make sure that the force is transmitted properly through the kinetic chain. So to do this sort of core exercises, you can do the PNF by being on a Swiss ball. Okay. You can do it bilaterally going upwards, yeah, in scaption position, but holding your core. Right. You can do activities such as planks. Okay. Now you'd think, how can we do plank if it is hurting? On the later phase, even if the pain is not there, you need to strengthen it. Now things like holding a plank position, okay, then lifting one arm up, okay. So this is my affected shoulder, lifting one arm up. Now a simple progression of that would be, in this position, touch 3 points, 1, 2, 3, 1, 2, 3. A progression of the plank would be on a ball. Be mindful that this can be pretty difficult to do. So I would suggest start with the kneeling position with the arm, shoulder being right above, and then move your arm sideways. 3 points, 1, 2, 3, 1, 2, 3. Then you can basically go for the plank position here, hold the shoulder, and if you're strong enough, I'm not, certainly not, you can lift your arm up. Proprioceptive exercises are also quite important. So in the initial phases, you can start with proprioceptive sort of activity of the shoulder, right? Very basic. Then moving on, activities that promote co-contraction. Okay. So these are a range of exercises you can do. Okay? Now, one of the critical thing is this problem occurs because of biomechanical errors. Okay? Now, if a thrower is throwing with a chest, open chest action like that, they're going to have this problem. If a tennis player is hyperangulating, they're going to have it. Now, although we know about sports biomechanics, we are not coaches. Some athletes find their positions advantageous. Okay? So what I would strongly suggest, work with the coach. Tell the coach that this is causing the problem. Can we modify it by some means so that they don't have to open up their chest quite a lot? If they do so, they're going to end up with the problem. The career would be shortened significantly. The coaches usually respond. Also, you need to think about the sports psychology. We often ignore in physical rehabilitation, we ignore about the psychological aspect. If you think about a sports person and their main job is to play sport, they're not amateur, they're professional. Their livelihood depends on it. They often hide injuries, okay? They're not confident about talking to physiotherapist or the coach because they think that they might lose their position, okay? Or they might think that they would not be able to play the next tournament if there is an injury, okay? Take them into confidence. A sports physiotherapist is I think a sports physiotherapist's main role is to be friends with the sports person before trying to treat the individual. So encourage them to be, if it is team sport, to be in the team, even if they are not playing, particularly like tactics and other aspects. Let them do lower extremity training when it's been done with the team. If it is individual sport, you have to tell them about how people might feel in the different phases of injury. People generally feel shock, grief, anger, and then they recover. So it's the cycle of grief that happens with injuries as well. So as sports physios, you need to think about the issues holistically, not just the shoulder. Okay, that's it really. I've talked too much, far too much, I would say. So just to recap, we started with the biomechanics of overhead sports. We learned about the wind up, cocking, acceleration, release, and deceleration phases in this. We then learned about why might there be posterior impingement. We learned about scapular, lack of scapular stability, posterior capsular tightness, and also anterior instability, rotator cuff weakness. We then strategized as to the management in terms of exercises, and we also thought about the psychological concept. One thing I missed out is that because there is posterior capsular tightness and AP mobilization, anterior posterior mobilization of the shoulder also happens. Now these management that I have discussed are based on the recent evidence in management of posterior impingement. If you need in the future, I can give you the citations and references of the articles I have used, mostly to do with Launders, okay? And also there is one debate still in terms of management, okay? Now, the debate is whether we should go for a horizontal stretch for the posterior capsular tightness or a slipper stretch. Now, just to show you how the slipper stretch works, you see this is the affected side. You'll be in this position and you'll be pushing the arm down. Okay. Now, McLeod and Launders have debated which one is the best. They found out both are equally effective and they are not 100% effective all the time. With that note, I'll finish this presentation and leave it to Dr. Reena to conclude. Thank you very much.
Thank you so much, sir, for this wonderful presentation.
My pleasure.
And the way you presented everything in your home setting, it is really appreciable. And
Thank
a
you.
special thanks to Diksha. She handled the camera very well.
Come on, come over. Yeah, come over. Say hello to everyone. Come. Yeah, this is my daughter Diksha. Okay.
Hi.
Say hello.
Thank you so much, Diksha.
All right.
Sir, there are just a few queries.
Yeah.
The first query is that how the posterior impingement and internal impingement, they are same, or how are they same or different?
Yeah, the terminology is exactly same. The posterior impingement, I think I'm running out of battery on my head phone here, so I might have to use the phone's audio here. Okay, just give me 1 second, please. Oops. Can you hear me? Hello? Rina, can you hear me?
Yes, sir, but you have to speak a bit louder.
Okay, okay. Now, posterior impingement and internal impingement are the same thing. They're synonymously used. Subacromial impingement is also called as external impingement. Okay.
Okay, sir. Okay. Sir, one more question. What does hyperangulation of scapula indicate specifically?
The hyperangulation of the scapula means that the scapula is not retracting enough. Okay. So if the scapula is not retracting enough, the glenoid faces slightly anterolaterally. Okay. And that means that the shoulder has to go more posterior to generate the force. And that's called the hyperangulation.
Okay, sir. That's it, sir. It
Okay.
was really a very informative and fruitful session, sir. Thank you so much for enlightening us. And we look forward to have more webinars with you in the future.
Pleasure
Thank you
is all
all the
mine.
participants. Thank you, Dr. Kaushik. Goodbye, everyone. Have a good day.
Okay. Thank you.
Hello. 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 एक कर रहा हूँ